I'm very grateful for his help and advice as always. We carried out an audit of what we called ERICA, which, if you can see the slide, stands for Enhanced Recovery with Integrated Care Assessments in Head and Neck Cancer Surgery. And we had a look at what happened beforehand, and then had a look at what happened afterwards, after we'd employed all those changes. And the ideas were to really try to minimise the stress responses during and after surgery, optimise the preoperative condition, optimise everything during the hospital stay, and keep the well afterwards, even discharged from hospital. And so we're trying to keep them going with function and improvement and healing, but also keep their mental well-being on track, and trying to look at that beforehand, during and afterwards, and keep it going. We think that's very important. So this was a retrospective audit looking at the incidence of morbidities and mortalities. We gradually introduced new changes to this, and so it was looking at a spectrum of changes over a period of time. And then we carried out a prospective audit to look at what had actually happened. So initially, we had a sort of rapid pre-assessment with a dedicated team of trained nurses, and if there were any problems coming up, they would email the surgeon and the anaesthetist, let them know what was going on, and also try and pick up on whether there were any ongoing concerns regarding mental health or anxiety, as there would usually be some element of anxiety which would be considered normal, but also to pick up on all those cases where there was an excessive amount, and then channel those patients appropriately. We looked at standard assessments in pre-assessment: blood pressure, ECGs, cardiac testing, and bloods. We had a consultant restorative dentist looking at their teeth and their status of dental health, and giving advice on what can be done for these patients afterwards, and pointing us in the right direction for that. It was important to stop smoking as soon as possible, or at least reduce it as best we could. And we asked for GP input regarding alcohol cessation, but that was very, very sparse and scattered actually. So smoking and alcohol were difficult ones to pin down. For the dementia screening, we had one of my elderly care consultants looking at patients who we felt were in need of more assessment and more help during the hospital stay and afterwards.
Sorry, Andrew, can I just interrupt you? Are you moving the slides on? We're stuck on the first one at the moment.
Yeah, I've moved the slide on. Yeah.
Oh, it's not moving on our screen.
All right. Okay. Where am I then?
Do with that.
Andrew, would it be possible for you to unshare and try resharing again and just double check? Oh, something's moved.
Oh, something's happened.
Have we got something on now?
Yeah.
If you could go to slideshow at the top of your screen, and then it might let you full screen it. Just next to review.
At the top of my screen?
Yes, so you've got
the drop-down menus. You've got File, Home, Insert, Design, Transitions, Animations, all at the top, and then Slideshow is the third one from the right. Right at the top, above the buttons bars.
No, I've not got any of those actually. I've got raise your hand, I've got more actions.
No, this is in your actual PowerPoint presentation.
Oh, within my PowerPoint?
Yeah, so if you look in your PowerPoint and you go up to slideshow.
Yeah, I've gone to slideshow.
That's great.
But I've not got any more, but
never mind. If you can, as you go through, if you can make sure that you click on each of the left-hand side slides, that will make sure that we're able to see the one that you're on. That's great. So you've just clicked on number 6.
Yeah, okay. Right, so let me move up a little bit more now then, if I can do that. So we've gone to that one, gone to 3, gone to 4. Okay, can you see slide number 4 now?
Yeah, we can. Thank you.
Okay. Apologies. So I think I was down to saying that the elderly care physicians were looking at our over 70 patients, over 70s patients with respect to their dementia status and guiding us through that. And then coming on to Paul's input here with anxiety and depression scoring, with his specialist psychological input, and using a combination of the PHQ and the GAD score as well. We had also scoring from our dietitians with this MUST scoring, making sure that patients weren't either particularly too underweight, but also looking at the ones who were particularly, scoring obesely as well. And then we had from the pre-assessment team carbohydrate loaded drinks given out to patients. So normally patients are starved before their anaesthetics. We sort of changed the balance of this within enhanced recovery to feed the patients effectively, and they had a couple of preload high carbohydrate drinks at 7 a.m. in the morning, a couple of hours before their surgery. Moving on to slide 5. So we moved to admitting them on the day of surgery. We thought we'd try and shy away from the tracheostomies as much as we could, because that also delayed patients' recovery. We also moved to simultaneous operating, so that we'd be doing several procedures at the same time for the patient, rather than just doing the neck dissection and waiting to go on to the formal resection or waiting to braze the flap. Everything would be done at the same time, and this sort of concertinaed the procedure and led to a reduced time of anaesthesia, a reduced operating time, and we thought that was better for the patient. We had some fluid monitoring going on at the same time as well by the anaesthetist, so that they weren't overloading them with fluids, but neither were they not giving them enough fluid as well. We were very concerned with the temperature control, because we know that when patients' temperatures fall just a couple of degrees from the baseline, then that induces a whole series of postoperative complications. We were looking at their glucose markers during surgery, and also the lactate, which is a sign of sort of metabolic instability, just to keep them going carefully. And you might say, well, surely all this is done anyway, but in the past it was all done in a somewhat ad hoc and not in a particularly ordered framework. So going on to the stages of this, postoperatively we had an operating notes pro forma. So we tried to keep things as standardized as possible, and it was a good reminder to us as well, because after a long operation, the last thing you want to do is sit down with a blank piece of paper and start writing what happened at sort of 8:30 that morning, when it's now 6 o'clock in the evening. We had a special free flap monitoring chart that was very sort of comprehensive. We had a ward progress document, so that several people could add to that on the same page, that we could see it. We were all electronic at the moment as from last week, so that will all be changing. And every day we had consultant review for these patients. We had early occupational therapy assessment, and the discharge plan was intimated even on admission of the patient. We gave the patient a diary so that they could log their concerns down, and it also acted as somewhat of a pacing guide for them, so that they could see where they were on day 1, day 2, look what they're aiming for, and they could add to this diary also at the times when we weren't at the ward round. And obviously when we do come for the ward round, there's quite a few people around, and patients are not always open about how they feel or their concerns, and sometimes they don't have time to get all these concerns out. So we felt that the diary was a very good option, and then they had a discharge pack to go home with plans in that. Moving on to slide 7. So looking at the audit data, the initial duration was from 2014 to 2015. We had 40 patients in that cohort, and their average ages were between 60 and 70 years. In the post enhanced recovery and integrated care assessment, that was done between 2016 and 2017. We had 47 patients, an almost equivalent number. And again, the cohort was just a little bit older, 70 to 80 years. Excuse me. Moving on to slide 8. Looking at the sites of the primary tumours, before the ERICA, we had mainly tongue, 47%, and post ERICA we had mainly tongue, 41%, and then other areas dotted around like the palate and the mandible and buccal mucosa. They were equivalent and probably not statistically different. Looking at the stages of tumour, they were yes, there were 1 or 2 highs in the in some bands there, but they were basically the same. We didn't change our head and neck MDT team. We didn't change any decisions around, and we didn't feel that there were any other significant changes that we made to management other than these things. So looking at reconstruction, yes, there were a lot more free flaps done in the pre-stage than the post-stage, but the decisions were by the same MDT, and that we think represented the cohort of patients that we had rather than a change in thought or planning. So the overall complications looked at pre-ERICA were 50%, whereas in post-ERICA they were 34%, and we think that is statistically significant. Medical complications beforehand 27%, afterwards 9%. Surgical, perhaps not too big a gap, 32% to 25%, but when you look in greater detail at what the surgical complications were, then they were a lot less. Hospital stay, looking at morbidity and mortality, hospital stay 16 days for the pre-group and 10 for the post-group, and that's not because we were just a bit lazy about sending them home afterwards. They were truly good to go. Strange things that came out of it, that the tumour recurrence rate had dropped 32% to 15%. That's 50% less than it was in the pre-group. We can't explain that. And strangely enough, the mortality also reduced from 28% to 9%. And looking at the recurrence rate, 23% of those in the pre-ERICA died from recurrence of the tumour, and only 6% of those in the group died of the recurrence. So we're finding it difficult to completely explain exactly what happened by this, but in conclusion, the reduction in the length of stay was 6 days, the reduction in return to theatre was 16%, reduction in complications 16%, surgical complications by 7% down, medical down by 18%, and disease recurrence down by 17%, mortality by 18%. Who can't say this is working for not so much the increased cost, but the increased effort in putting all these measures together? So I'd like to say it's all because, you know, we had these patients better assessed on the anxiety and depression scale. It's not only that, it's everything coming into it, and it's difficult to pick the one reason behind all these improvements, and that's probably because I don't think there is one reason, and it's a collective reason, but each parameter I think supports the next one in a very positive way, and it's just to get all of these moving in the right direction quickly at the right time frame to get the patients sorted out. So I think that's the end of my talk. I won't expose you to my last 2 slides because I'm not familiar with the total audience, but I'll take any questions that you might have from there.
Paul,
thank you.
Thank you Sorry, Andrew, thank you so much. That's been really, really helpful. What we're doing is, if you can stay, we were planning on having a sort of panel towards the end of this talk, but I don't know whether you've got other commitments that mean you've got to dash off.
What approximately what time would that be?
Well, we plan to finish for lunch at 12:30, so it would be, but are you able to do that, or would you prefer questions to be done now, because we don't want to hold you up any more than you need to be held up?
My preference would be for questions now, if that's okay with you. Okay,
so can I ask people to put any questions that they've specifically got for Andrew into the chat now? Because I think there's been lots of very interesting information, and obviously you've approached this from a much more holistic approach to supporting the patient, looking at all sorts of aspects, including their mental well-being. So, and I know it's very difficult to disaggregate, but how has it helped to have someone such as Paul, or Paul, in as part of the team?
I would say it's almost been crucial to it, really, because without that, then we're on a limb, and trying to get ourselves involved in that is difficult. We don't have the tools for dealing with that. Some of our staff, some of our allied workers have a little more time to spend with these patients, but again, they don't have the assessment tools that they can adequately use, and they don't have the pointers to put these patients into different treatment brackets. We do have a hospital psychology service, but it's so overrun at the moment that to get patients their appointment, it would be sort of weeks ahead, and we don't have that time frame. So we need things now, straight away. Almost as the patient comes in, we need the PHQ assessment and the GAD-7 going, and we need to give those things to the appropriate people to put them into the next bracket or the next level of psychological help, so that they can be helped really through their course of treatment, because otherwise we're just fighting against a fire that's going to cause them real problems later on. And the last thing that we want is patients who are not able to either go for scans because they're frightened of that, or even just little needle phobias and things. So all this is crucial to the help, but it's lots and lots of different factors.
That's great. I mean, Claire asked a question, do you have any thoughts about what would be the effect of not having the psychological input in the team? I think you've already quite easily described the benefits of having it in there, and you've also described with Erica the difference between before and after, although that has been a much more holistic. Have you had, Anne is asking, any feedback from patients on the support that they have had?
We haven't specifically looked at a tick box chart of that. We get lots of thanks from our head and neck patients. We rarely get complaints about the service or the treatment that they've had. I think for those patients going through in the post-Erica group, they have just perceived it as, we've been really very nicely looked after. Thank you very much. Obviously, not everyone in cancer treatment is a success, because it's a little unpredictable and we can't give everyone a guarantee. But I think on a holistic pathway, we've tried to tick all the boxes in smoothing the way out for those patients, and some of them with, severe anxiety problems. We are never going to cure those patients, especially when they've been given another insult to sort of, add to their pressures, really. Yeah.
That's okay. Claire has asked, this is Claire Rockcliffe-Fiddler, has asked, are you able to bring a case or two to mind that will illustrate the importance of the role of the psychological input that you believe would have had a different outcome without it?
So there's a few patients who've had, particularly severe anxiety episodes. One of whom, yes, he was really quite aggressive with his anxiety. He was a young chap. He'd been exposed to all sorts of, drug abuse in the past, and I think he was able to be calmed down sufficiently so that we could get him through the pathway, get him treated. And then we normally try to review these patients for a 5-year period, but he just found it too taxing to come back regularly for any more appointments. But on his final visit, that he decided was his final visit, only less than 6 months from his surgery, he brought me a big Banksy picture of the angel with wings and said, this is for the team. Thank you very much. You've been my, Banksy angel with wings. So that's one. So from a very aggressive bloke who had lots of problems in the past, and we sort of, made life more uncomfortable for him, certainly, but hopefully, remove some of his tumour, then he was extremely grateful for that.
Brilliant. And finally, because I do know that you need to get off, have you any thoughts about this as a specific role versus training everyone in your team in these kind of skills?
So if we only had time to encompass and harness all these skills, that would be great. And, I try to keep them in my mind all the time, but it would be just super if we had someone who we could say, we're happy to say, yes, fill in the GAD-7 or fill in the PHQ-9, but please, would someone else look at it and take over who's got a bit more time in a quiet situation, a room, and can even, contact these patients by telephone, otherwise, and guide them to the next level of support should that be needed. So I think relying on ad hoc members of the team and, to say, oh, this is a clinical nurse specialist activity. No, it's not, because they've got lots of other roles as well. And OK, let's give it to the dietitian because they've got a bit of spare time. No, they haven't. So no one has the time and capacity to deal with this. And I think it's an ongoing learning exercise that person would just get stronger and stronger with their advice and their treatment of these patients.
Okay, that's great, Andrew. Thank you so much. I think, given that you are obviously under a lot of time pressures, we're really, really grateful to you for turning up this morning. And we really welcomed having your presentation and thoughts about the role of assistant practitioners. So thank you very much. Good luck with carrying on with the rest of your day.
OK.
Get on well.
Thank you. Thank you very much for inviting me. Sorry I was late to the party and a bit slow in responding to other things as well. And then I had some technical issues with getting onto Teams, but thank you anyway. OK, good luck with the meeting.
Andrew.
OK, take care. Good luck. Thank you. Bye-bye.
Bye. OK, that's great. I think that probably brings us on track, so that what we will now do is move to Rachel, who is hopefully somewhere in the audience and is happy to talk about her bit, which is putting the pieces in place. And I'm sure Rachel will introduce herself, so I'll leave her to do that. Thank you.
Thank you, Sinead, and thank you, Polly, for having control of my slides. It's always great, isn't it, to see a professional actually working in the office, because at the moment we're in Zoom and Microsoft Teams world, and we see people's bedrooms. So it's really nice to see that actually people are working in hospitals. So it's great to hear from Andrew there. So first of all, I want to introduce myself. My name is Rachel Wylie, and I'm the lead for the CYP Mental Health and Perinatal Mental Health at Health Education England, working across the Southwest. So I work with Anne Horsburgh, who was chairing this meeting, and I work within the transformation team. My title on the agenda does say Education Commissioner, but that's slightly out of date now, but it has been useful being an education commissioner. So we have heard so far today about the fantastic innovative work that's been happening in the RD&E across the Southwest, within the Southwest. So a massive thank you to Andrew and Paul and Alexander for what has happened and what potentially could happen, and not least the elusive Erica, who has been mentioned in Andrew's last presentation. We heard about the developing new role. We've had a bit about the model of education behind it, and I know there's been some chat going on regarding the educational aspect of it, and I think there'll be more on that this afternoon as well, looking at what the Northwest has been leading on. And we have had a look at the evidence for the benefits for both the patient and for the system, and also for our finance colleagues, which I think is always really important in the NHS. So in this session is a bit of a time to reflect, and I know there's been a lot of chat in the chat box and a lot of questions and commentary and conversations, which has been great, but this is really to allow us to find out how we can spread and adopt this role in the most beneficial way for everybody. There is only one Paul. He can't work everywhere. He's wonderful. We all know he's wonderful, but he can't work in all the medical specialisms, and we need to make sure that this role is expanded. So I've got three quick questions to start with, and I really would like you to put your comments in the chat box about it. So my first question really is, actually, can I just ask, what time do you want me to finish?
Can we say you've got half an hour?
Well, I won't need that much.
Till 12 o'clock, but if you take less time, then we've got more time for questions.
Okay, I will try to take less time because I know there have been lots of really good questions. So my first question, Polly, if you could put up the first slide, is what do you think? What is your first thoughts about this role? Are you interested? Have you been enthused? Do you need to know more about this? Would you like to be involved with trying to adopt and spread this role, perhaps in your organisation or perhaps across different areas? And I suppose part of that question is specifically for the Southwest, where we haven't seen so much of this assistant practitioner role within any areas of mental health. Do you need to know more about the assistant practitioner role in general? So those are my questions. I'll be happy if you want to put as much as you want into the chat so that we can actually have a record of what you're saying. This is recorded and your chat box information is recorded. So just to try and get you to sort of think about what has that been interesting, useful? Did you know about it before? Basically, what did you think? So go ahead and put something in the chat box. That would be really great. My second question really is, can you see this role in your organisation? How can you see it fitting in? And if you can't, why not? What would stop you putting this role? I think that's quite an important question as well. So yes, it can go in my organisation in maybe this department, but also I don't think that's going to fit. And I think it's really important for us to know the barriers of why this role can't go somewhere else. We've already got somebody who said they'd be interested in going into stroke, which could be really quite an interesting area. So my third question is about where this can fit, and I put psychological in there by mistake. It should be assistant practitioner. Apologies for that. But it's currently in head and neck, and Alexandra has mentioned the potential for renal earlier on this morning. But can anybody else think of anything anywhere else that it could go? We've mentioned stroke. You've just, I think, I can't remember her name, has just mentioned somebody about it going into stroke. So any other areas where you think you could identify a medical specialism where this would be really useful? And if you are a department yourself, which would be really keen to find out more, just slot that into the chat box as well, because we're hoping to garner some enthusiasm, some motivated people to work behind that. So loads of stuff coming through now, which is great. I can see that this could go everywhere, but please carry on putting it into the chat box. So for the next part of this session, I'm going to talk about the development of how we can spread and adopt this. This has been so far a bit of a one-off innovative area, and we want to spread this much further. But in the NHS, I think it's fair to say that we are generally really rubbish at spreading and adopting new ideas. Not that we don't have lots of ideas, it's just we don't spread and adopt them very well. And this quote from the Health Foundation probably sends up a little bit more diplomatically than I would. Too often promising innovations remain on the margins and benefiting lucky few, but leaving the majority with poor outcomes and experience. So we really are keen to spread this. I want to introduce you now to a framework that for spreading and adopting a workforce innovation. And this, I have to say, is not my framework. It is been produced by the National Transformation Team in Health Education England. But I'm going to summarise it very quickly, just to let you know where we sit in the time frame and on the timeline. And I've taken the next few slides directly from the framework, and have put the link to the framework at the very end of the presentation so that you can actually read more into it. I want to acknowledge that it's not me, it's not my work. It's actually mostly produced by Helen Podmore and Juliet Swift from HE National Transformation Team. It's not rocket science, but it does provide a handy summary of the steps required to spread an innovative idea. So I'm going to go through the 5 stages very quickly. Very simple. There are 5 simple stages. The first 2 are about the initial idea and actually getting it together and getting it neat and packaged up. And then from step 3 onwards, it's really about how to spread and adopt this. So I think step 1, we've analysing the original idea, is complete or is being completed at the moment by Paul and the work that he's done with Andrew. And we are just starting to really look at step 2, which is about spreading the message. And today is basically that. It is about spreading the message. For step 3 and beyond, will require greater participation from more people, and that's where you and interested parties come in. And there are 3 questions I asked you about earlier which will help with that. So we're going to look slightly more in depth. So Polly can go on to the next level. Paul has very clearly evaluated, along with Andrew, the current innovative idea and presented the local context. He's recognised the attributes and provided us with benefits which are excellent. Which will benefit patients, service and the NHS as a whole, because there is a lot of money to be saved using this innovative idea. Step 2, spreading the message, as I've said, is about today. Paul has created a story, providing you with the levers and the hooks he used. And today's the start of the communication and engagement plan, which is the last part of there. At the bottom, you'll see establishing a social movement or network. And we have the PPA network, which is great, but we might need something else to sort of push this idea forward and to spread it forward. But that's where we'd like you to be involved with coming up with some ideas of how we can do that. So to address some of the issues, Paul and he have been working together, and we are putting in place some pieces of the parcel. Bid has been successfully approved, and we will be looking at the next stage, which is promoting and development of the new assistant practitioner medical speciality role. Paul is working with Health Education South East in a phased approach, and you can see the 4 different phases there, but it's really important that we have participation from other people. We are raising the awareness of the role within South West, and we'll be doing that in a number of different ways. We will be looking very much at the education and developing a competency framework, which is happening at the moment. And we are looking for people to be involved with that and to help with that. So if you are enthused and want to be involved with this, please do put your message in the chat box, and we will follow up on that. So step 3 is about you. It's about getting your organisation ready for adopting and adapting to this. So you need to think about how you will suggest this to the board. Should it go through SDPs? Should it be an organisational thing? Do you want it to be, a more of a wider system approach, perhaps a regional approach? So you need to start your organisation to get ready. I strongly believe that one of the key elements in engaging the right people is one of the key elements is actually engaging the right people in this so that you can push this forward. And I've included a slide, the next slide, which is about influential individuals and the characteristics you can have. I've worked on the approved clinician role, which we're now trying to spread out, and actually having people behind you with enthusiasm to make it work is really, really key. So I've just highlighted the from Appendix 1 of the framework, what type of people there are. So in the next step, Polly, if you can just move on. Thank you. Is about actually doing it. And this to me is very much the project management slide. We know about setting realistic timescales, about evaluation and things like that. And there will be people in your organisation who will have project management skills. So some of these people may be the people you want to go on a support from. Stage 5 is the final step. There's no point in doing innovation if it doesn't work, so it doesn't continue. This is about making it become business as usual, and it's a really important part. It's about celebrating what you've done, but making sure that it continues past the initial enthusiasm that people have. So that's the framework, very simple as I've said, but it does give you something to hang the process on and something we can hang our process on as well. So Polly, can you just put on to the next one? I've mentioned a slide. I mentioned that we have put a process in place to try and move this on in the Southwest, but we're really keen to get this adopted, adapted and implemented and sustained. So my next question really is, do you want to be involved in the next step? If so, put your name in the chat and we will follow this up. We want to know what support you need to make this happen in your organisation. Do you want a better understanding? Do you want to know more about the levers, the barriers, enablers? And what support do you need perhaps internally within your organisation, but what support do you need externally? Do you want there to be more support and promotion of this via the PPN network, via your SDP and ICS leads? Do you want a more regional approach? How would you like us to help you adopt, adapt and spread this innovative idea? So just keep ploughing things in, as I can see people are, which is great, into the chat box, and we will sort of sort through and see if that can help us shape how we can get this great idea out to the masses. I haven't got any questions, but I know there isn't any questions session coming up, so I don't know how you want to play this, Sinead.
Rachel, thank you so much. I think that's been a really helpful way of looking at how we might get this model going forward. I think what I'll do is I will summarise what I think I've heard this morning, which people can argue with then, and then once I've done that, then we can actually move forward to questions. There's been loads of questions coming in, loads of chat going on, which is great to see. But yeah, thank you for your input, because I think it is about making this a reality if that's what people want. So I think this morning we've heard from 2 acute specialists, which it's really great to have them come in at a really busy time of working in the acute sector. We know that it's difficult and complicated by COVID. But I think what they've described is that there are complex and complicated patient pathways that lots of people are having to deal with. Some of those are around long-term conditions, and we heard from Alex how, you know, people with kidney disease are living with kidney disease for a long time. They come in, they're obviously upset, and they go through a very complicated care pathway, which may end up in resulting in dialysis and kidney treatment. And during that time, they will experience a number of issues and concerns about their treatment, both in hospital and during aftercare. And some of those are related to the input from the acute trust, and some of it is about their own self-perception after they leave hospital, so their body appearance. Alex described how he considered that supporting people holistically, dealing with their psychological issues as well as their physical care, was essential, not only to support their mental well-being, but also to support their ability to manage their life once they are outside hospital. But clearly, having an assistant practitioner role wouldn't be everything, and it's really important to understand that that role could also provide referrals to IAPT and other psychological support services. We heard from Andrew about the care and assessment audits that had been carried out in previous years, and how various parameters, including things like diet, alcohol, smoking, as well as anxiety and depression scoring, all impacted on the patient's well-being. So again, looking at that holistic approach, and clearly by making that more organised and central, that having all of the different team members in there could really improve patient outcomes. And I think that's really important to focus on. He didn't claim that this was all to do with the role of Paul being in the team. He did say it's a holistic approach, but what he did say was that there's no one team member that can deliver on everything, and having a role where they have someone on tap, on demand, who can provide the psychological support was critical, and that couldn't be delivered by other team members, although they might aspire to work in that holistic way in everything that they do. Paul described how the role that he envisages could happen would be something that is adapted from a role that is already there. We have assistant practitioner roles, so this isn't something new. This is just looking at it from a slightly different angle and supporting those assistant practitioners to be trained up to support people with a particular problem in the acute sector. So they're not going to be a one size fits all. There will be different assistant practitioners in each of the acute specialties who would be enabled to understand what that acute specialty needed support to deliver on. Finally, I think we've had a really interesting presentation from Rachel about how the assistant practitioner roles in acute specialties could get off the ground. It's not a new role, as I've already said, it's adapted from an existing role. However, she was keen to explore the barriers to having such roles. We did get feedback while she was talking that some things were around the funding, about where it sits within the current roles in terms of psychology, health psychology, liaison psychology, the IAPT service, who are obviously crucial and major contributor to working in the acute sector, and then where it might sit within the different specialties within acute care. And suggestions came in including chronic pain, stroke, gastrointestinal, epilepsy and MUS. Rachel described that often what we do is we have these great ideas, but we're not always good at spreading and scaling up innovations. So the old adage of islands of excellence in the sea of mediocrity springs to mind. So we need to understand how we can adopt innovations such as this, specifically this, and spread it using a data-driven and very analytical approach to all of this, using the 5 steps that have been developed to encourage organisations to work together to get such great ideas from pilots and trials into business as usual. So that's my summary of what I think I've heard this morning. And it is a quick run through. This afternoon, I would like to reiterate that what we are doing is focusing very much on how this is put into practice. So looking at apprenticeship schemes, looking at how the assistant practitioner role is already working in the Northwest, but really open to other questions. So would you like to put forward any questions, or I will pull off some of the questions that have come through so far? Okay, I'm going to start off. The first question that we had way back at the beginning was, is COVID impacting on patient journey care pathways? And does this strengthen the case for a skilled support role? So I don't know whether Alex or Paul could comment on that.
Just to come in first, I think absolutely. We've heard time and time again from patients that because many patients in the kidney service are in the shielded group, they've particularly struggled with the fear of the infection, and also the sort of social exclusion and isolation that they've experienced. There's been a platform called Beam for Kidney Disease, which is a sort of online platform which incorporates exercise and well-being. So that's been nice to see innovation like that arise. But the data from that platform has shown that there's been a lot of sign-ups and then not much maintained activity. So I think the opportunity to develop support for patients during COVID has been there, and it's been nice to see it. But I think there's still a lot of concern about the shielding from our patients.
Could I just chip in there as well? Can you hear me?
You're on mute, Sinead.
Yep, can hear you. Chip in, Paul, by all means.
Okay, in terms of the COVID, we've actually developed a step 1 COVID prevention approach as well, which is informed by low intensity competencies, but is not low intensity. So it's targeting specific difficulties that people are reporting with COVID, such as getting structure back into your life. So we've developed, and we would adapt, and me and Alex are already having a chat about adapting this prevention approach. So it's not within step 2 or above of the step care model for particular COVID related challenges. So we could see how that could be adapted around different specialisms, given the specific demands overlapping with COVID that different specialties may have.
Thank you. The next question is very much focused on the role of IAPT and the role of this role. How they will integrate. So the first question is there a risk of a less experienced assistant practitioner embedded in a medical team becoming isolated, not well supervised, and drifting into more of a therapy delivery? So that's the first part of the question. Paul.
Well, there's always that risk. But as we know, with IAPT, when it was set up, we had very firm structures to stop especially the PWPs drifting into step 2.5 or 3. We had accreditation mechanisms surrounding it to stop the drifting. Actually, where there is drift, it's very clear it's come and been led from services themselves directly. So in terms of the supervisory arrangements across the board, then that's something I touched on in my presentation, that we would need to understand and be very clear around the supervisory arrangements, because one of the functions of that job would be to ensure that there is no drift into step 2. So really, this actually comes down to how it's managed across services and we will put the implementation structures in more generally.
And so that's all about being at the design phase, making sure that we have a system which actually looks at the supervision needs of these individuals and make sure that there is a program that develops up that includes the supervision and monitoring of the support that they deliver. Next one was, could it also impact on IAPT access step 1 development elsewhere within the community framework? Sorry, step 1 development elsewhere within the community framework has drifted into step 2 and impacted on IAPT access. So I don't know whether you feel there's anything that you want to add on that.
As far as we haven't got this assistant practitioner role running yet. So there can't be any drift from this role because it's actually not implemented yet. I can see lots of opportunities where it will enhance IAPT,
maybe
such as picking on patients.
Whether there's anyone in the Northwest who might be able to comment on that.
Yes, hi. I think what's important is that it's been very clear about the skills and competencies and the level of the AP role, which are very clearly defined and distinct. So I don't know if Kay wants to add anything about that. I know that she'll cover that this afternoon, but she might just wants to say something about it now for people that can't join.
Yeah, hi there. I'm Kay Heliwell. I'm the North project lead for assistant practitioners. I think really what's really key with this role is that it's embedded from the beginning. It's got clear structure, it's got clear job role, and therefore that drift should then not be an issue. The idea is that it's a support role, so it's there to support the professions. So really it's about how well we embed and get that structure right from the beginning in terms of competencies, jobs and job roles.
Thank you, Kay. I think that actually answers sort of, Sue again is talking from a Devon perspective, that within the RD&E we have an integrated psychological medical service, an IAPT health psychology and liaison. So and in terms of the role within the RD&E, it's about how it would be linked or whether it be entirely separate. It sounds like that it's important that within the planning stage you develop up the clear integrated approach to all of this so that people are very clear about what their role is and what IAPT role is, what health psychology, liaison psychology, so on and so forth. So
maybe I could just add something further to that. It kind of goes back to that workforce planning and truly understanding what the career pathway of this role is. And I think once services get that understanding of where it starts, where it may go to, how they see the role working, all of that then comes into play and you've got a good, well-defined role, and therefore that should alleviate that role drift. I think there was also a question about, does it take, maybe I could answer this one also, does it kind of impact on the numbers accessing IAPT? Again, I think, if we go back and we've got that good structure and the role definition, it will actually increase the numbers that go into IAPT services, not take numbers away, because they'll be accessing different parts of the system, people that otherwise may not get access. So I think ultimately what it will do is increase workload for IAPT services rather than decrease.
Which is great, because obviously they've got clear key performance indicators and goals to meet. So we don't want to say this is instead of, this is, as you say, enhancing very much the access that people will have to psychological professions across the board. I know Paul did touch on this, but in terms of a question came in as, can we define the competencies for this role? Do we have a competency framework or could we develop one? And I wonder, Kay, whether you could say, clearly, I mean, this is slightly different from the assistant practitioner role that you have in the Northwest. Well, it is fundamentally different, but the same. So you must have already a defined competency framework for that role.
Yes, so within the apprenticeship standard already, there is already a general framework. What we've done is work with the universities to get a deeper, a more deep-rooted mental health element across both years. And I'll talk a bit more about that in my presentation later on this afternoon. But essentially, yes, the core competencies are already there, laid out in the apprenticeship standard. And I think one of my colleagues may well have posted the link to it within the chat function.
Brilliant. Okay.
Sinead, I can just see there's a couple of hands up. I don't know if they're old hands or if people are just wanting to add a comment.
I can't see hands at the moment for some reason or another, so it'd be really good to, do you want to take on who's got their hands up?
Oh no, sorry, they've gone down. It was my hand.
Lindsay Robinson's got a hand up, Claire, from UCLan, who is our trailblazer.
Yes.
University. I don't know if you want to come in, Lindsay.
Good morning, everybody. I just wanted to, just as we go to a period of break within this fantastic event, that when we're thinking about competencies, it may be something that and I will talk about more this afternoon, but the competencies that we can define within the AP role could be very service specific. So just thinking what Alex was saying this morning about body image, or very much focusing on an integrated approach, how each service builds that role within their specific service need. Can also be considered alongside the generic competencies that sit within the apprenticeship standard.
That's really helpful, Lindsay. Thank you.
Thank you.
I mean, I think there's been lots of really interesting chat going on in the chat room, and I noticed that Tim has suggested PWPs have observed that with regard to COVID-19, much more time has been needed to support patients due to socioeconomic factors, and this has increased stress due to struggling to find that time, e.g. job loss, financial hardship, increased isolation, and effects of these on both mental and physical well-being. And clearly, you know, I mean, I think Andrew's presentation very much described that holistic approach and needing to ensure that it's not one key thing that hits, it's everything, and dealing with some issues quite often will impact on improvements in other areas. So that's great. Are there other hands up? Because I can, oh, Phil's got his hand up. Would he like to come in?
Thank you, Sinead. Sorry, I was just, you've come to me quicker than I could type in the side, so I'll say it rather than type it. I was just picking up on that point about competencies. It seems really important for me from a psychological profession's point of view, not just from the specialist and kind of point of view, to think about how we map these competencies against existing other roles. I'm thinking partly to kind of define the role, but also to think about to aid with the supervision structures and to get some clarity around the different scopes with the different roles, because I think there is a risk of us being a bit confused about what all of these different roles do, what their scope of practice is, and therefore the governance arrangements that need to exist around them.
Thank you. Does anyone else want to come in on that? Lindsay, you've still got your hand up. Is that an old hand or is that the current hand?
Apologies, old hand.
That's fine. Andra Chiskop has got, no, sorry.
Yeah.
It's you.
No, it's me. Hi. Hi, Sinead. Thank you. My name is Andra Kiskop and I am a mental health project manager working in the northwest of England. I actually work with Kay and Claire on this. And just to answer Philip's question, we have developed, so everything started from a pilot test, a pilot site that was developed in the northwest with 3 IAPT services, and out of that we were able to develop 4 core competencies to support around the mental health delivery. And I'm sure Kay will be able to tell you more about this, but they include around supporting patient engagement, supporting community engagement, also supporting the delivery of psychoeducational groups. I hope for the time being this is an answer, but you'll be able to hear more in Kay's presentation later.
Brilliant, thank you, Andra. Johan.
Hi, good morning, everybody. Can you hear me?
Yes, we can. Thank
you. I was just wondering, and I did put in the chat about a project initiation document, because we, in my setting, which is with a massive hospital trust, and then we also have IAPT LTC, and we've got a project which reaches into the hospital. It takes a lot of planning and consideration to implement this effectively. The role as discussed this morning, I think, is fabulous because it's very neat. It aligns it close to the clinical interface. And in that sense, it adds self-evidently to the pathways, really. So I think if that is our starting point, rather than try to explain all the various and difficulties that can happen, but have a starting point and a PED that we can then debate and implement in our settings, we can drill down. My point is basically, I don't think we're going to resolve all of the questions in how it's going to impact on the system, but what we can say is that it's got a place in the system and we need to trial it and see how it works thereafter.
Thank you. That sounds really positive. We love to hear such positivity coming out of the morning session. Are there any other questions? Oh, Claire, have you got your hand up?
Hi. Yes, just on just to follow up the idea about the PID. I think the great thing about collaborating between the Northwest and the Southwest is that we've done a lot of the groundwork. So we're very, very keen to collaborate and help you not reinvent the wheel, but look at how we can actually put together the work that we've done together with the work that you're doing to create almost like a package and support. I think that kind of builds on Rachel's idea about, rather than things being isolated projects, that if there's something in it, how do we build on it and collaborate to support spread and adoption. So we'd be very keen to look at how we put our heads together on this and use resources that we've already created together with the innovation that you're bringing to it too.
Great. I mean, I'm just looking through trying to, what I'm seeing is lots of positivity from this. I think it's really important to recognise that, you know, we were probably pushing against an open door on the people who have come to this presentation already, because you clearly had some interest in it. We don't want to limit this to just the people at this presentation. So if you've got colleagues who you think would have been interested but were unable to get here, this will be a recording that you can actually listen to after the event, and we'd be very happy to ensure that other people have an opportunity to talk to us about it. So please do encourage colleagues to come along and listen to it after the event. And for those of you who are not aware of the Psychological Professions Network, we'd also like to try and encourage people to join that Psychological Professions Network in your region. You can actually join more than one region if you're interested. Claire has been running the Psychological Professions Network in the Northwest for a long time. We in the Southwest are much newer, but we are keen to increase our membership, whether that is people who are psychological professions or whether it is actually stakeholders. So we would welcome members who are stakeholders as well as people who are psychological professionals. So do try and share this presentation, and we'll be sending it out as a link to on our website after the event. I'm just wondering, are there any more questions? Are there any more hands up that I'm not aware of? Paul, you.
Can I just jump in then, just to sort of try and pick up on some things some people have said?
Yep.
So, well, partly of this is Lindsay made reference to some competencies associated with the role that they've already identified. So we'll be able to build on some of those to inform this role. Another speaker, some questions. These competencies, and I've pushed this again, these competencies will be a match between what the medical specialisms want and where there's evidence-based practice from a psychological perspective. So that's the matchup. So the competencies will develop because it's not psychological competencies being imposed on medical specialties. It's actually the match between what the medical specialties want and the competencies that an assistant practitioner could bring to those roles and would be appropriate for that level of role. In terms of some of the wider competencies, actually competency mapping would be a really good idea, putting my PWP IAPT advisor head on as well. We're aware in some regions that PWPs are doing things that actually there's no problem with them doing, but they don't need to do them. If we look, for example, on psychoeducation groups, if we go back to NICE on psychoeducation groups, it talks about specific groups around supporting self-help in groups at step 2. General psychoeducation along the lines of these being non-interactive, just understanding awareness and increasing understanding about the interface or about mental health problems is actually identified in NICE guidelines as a step 1. Therefore, within the step care model, this would fit perfectly within the competencies, also aligning with NICE in a step 1, not step 2 role. So what we need to be careful of is that services across the country, or some services across the country, aren't using PWPs in a step 1 function unless they want to. And of course, that's okay. But just to also think this may be a two-step process around things like that also.
Brilliant, Paul. That's really great. I think I'm not seeing any more hands up, I hope.
I just had
Claire
one.
still has a hand up.
It was just it was just to flag up as well that I suppose what we haven't captured today as strongly maybe is the feedback from the services that have been using the AP role in the Northwest. And we Kay has just established a steering group stroke AP collaborative that consists of service users and education providers. And again, there's some very strong narrative evidence from them, as well as increasing evidence around clinical outcomes that are being collected, that the role is really valued and is different. It's the additionality, I think, that's important to stress. So that's another element that we can tap into if going forward you need that voice to add to the taking forward any developments in the Southwest.
That's brilliant. And just to say that we've had David Payne saying that he, as a non-mental health specialist, we have an AP in IAPT that already does what Paul is suggesting and then work with PWPs when required. So there are, there's models that we need to consider about how this is best embedded. But the fundamental issues that we're trying to say is that within acute specialisms, there is a role, or we consider there may be a role for an assistant practitioner to work with that specialism, learn more about that specialism, support people on a needs-driven basis without having to necessarily wait for referrals to services which are within the hospital in general. I'm not seeing any more hands, am I? Paul, have you got your hand down? Is that an old hand?
Sorry, Sinead, I've just got one other point as well, if that's okay.
Fine, carry on.
It was just in case people weren't able to stay for this afternoon, but the other aspect that's really important with the assistant practitioner is that it also builds the opportunity for you to grow and develop your own talent. So this afternoon, Kay will talk about how this is a role that trains at band 2/3 and then is employed on band 4. So what that means is that you can talent spot people who maybe for whatever reason haven't had the opportunity to get the educational attainment that they might need to go straight into a registered profession, but that you can see that they've got real talent for care. So for instance, we've had examples of people that have been in administrative roles, working in mental health settings, who clearly would work well in a therapeutic role, but the mechanism for them to make that shift across it isn't available through going straight into a registered qualification route. So this allows you to develop the kind of clinical talent of people whilst they're training, which then takes them to foundation degree level, and then they can top up as part of their PDR, continuing professional development, to an honours degree, if that's what the service requires, which then allows them to go to the next steps in terms of their career development. So there is an inclusion and diversity element to this role as well that that we'll explain a little bit more about this afternoon.
Okay, I think we're getting to the point where people were certainly enthusiastic about what you were saying there, Claire. I think the other thing that we need to recognise is that we do get people with lived experience who may themselves be people who can support and come into this role and would be really good at being able to support that. Now, I mean, there are also peer support worker roles, but I think that, and people with lived experience do move into these roles. So we can talent spot from a wide range of areas, and we need to, at the end of the day, make sure that the person who is receiving that treatment has it put, they are at the heart of everything that we do, and we identify how we can best support them. And using this holistic approach, and this being one spoke into that person, is a really important thing to do. So without further ado, thank you to everyone for coming along this morning. We hope that you'll be able to return this afternoon. Apologies that I was sort of thrust into the role of chairing this, so hopefully I haven't done too bad a job, but fundamentally this afternoon someone else will be chairing it and hopefully doing a fantastic job. So many thanks for coming. And what time does it start this afternoon? I ought to know, but I haven't got this timetable in front of me.
1:30.
1:30. So we've got just over an hour. Do come back, and we look forward to seeing you this afternoon. Many thanks.
Thank you.
Bye.
Just wait for everybody to leave and stay on for a few minutes.
Yeah, have you stopped recording?
Oh, good point.
Yeah, that was lucky, Sinead.